Good afternoon, everyone. I'm greeting from Army Hospital Research and Referral. I'm a retina surgeon who went on to become a keratorefractive. I'm doing a refractive surgeries also. And for last 6 months, I've started doing this MIGS. And I found it to be a very interesting surgery. So my topic is my experience with the Kahook's dual blade that is gliding with KDB for the MIGS. I don't have any financial interest. So this is one which is used for the MIGS surgeries. It bypasses the trabecular meshwork resistance and it elevates and excises the trabecular meshwork to access the multiple collectors channel. The indications are it's used for mild to moderate glaucoma case trabeculoplasty, the patients who are non-compliant to treatment and who are experiencing drug reactions. It's minimally traumatic surgery. Modest yet sufficient efficacy is seen. It's a very good safety profile and very rapid recovery and does not impact the quality of life. So this is how it looks like. I will be showing this, the video also this. This is the Kahook dual blade. There are 3 parts. You can see the tip, which is very sharp, then the ramp and the heel, and the side there are the 2 blades. So the tip is very sharp. It pierces the trabecular meshwork. And then you seat the heel and you lift the trabecular meshwork and the side blades, dual blades, they excise the trabecular meshwork. These are the benefits that it excises the strip to access the multiple collectors channel. It is implant free. At present is the only drug which is FDA approved for standalone MIGS surgery. It is very versatile and this is for the excisional goniotomy. The preoperative consideration, who are the good patients? Anybody who is fit for cataract surgery and you have explained the patient well is a fit patient for this surgery. You have to have a preoperative look at the gonioscopy and you can see the angle very clearly. Then you are going to have less trouble in doing this surgery. Any stage of glaucoma, in fact, I've done, usually it is prescribed that you do in an open angle. I've done in few closed angle also where you are able to open up the angle with heel on. So where you don't attempt is that any patient with an active neovascular glaucoma, active uveitic glaucoma, where there is a raised episcleral venous pressure and the view of the angle is poor, and where you want a very, very tight control, that is the post-operative IOP of less than 10. There you don't attempt that. So you have to counsel the patient about the surgical procedure. I usually do all these cases under block because you don't want any movement of the eye, and you are going to use air bubble in that. So you have to tell the patient that the vision is going to be blurred for probably a week or so because there is also dispersal of the blood. So the vision is going to be blurred. It's very, very important to see the reflux of blood. You know, normally there is always when you see blood, you get scared. This is the only condition in surgery where you see blood and you feel very good about it that your surgery has gone off well. If you don't get any bleed from the angles, that means you have to rethink that your surgery is done in a proper manner. You also take a history of patient being on anticoagulants. Preoperative preparations like any other cataract surgery that use antibiotic drop preoperatively. Pilocarpine in case you're doing a standalone cases. I've done few standalone cases including one gynecologist and a dermatologist. You have to tell about the patient about the preoperative. Tell the patient you have to tilt the head to an angle, and patient should not feel about it. You have to tell that. Otherwise, patient may say, "Why you are tilting my head?" When doing along with the cataract surgery, you have to inject pilocarpine to constrict the pupil and to have a better look at the angle. So the 3 techniques is, one is an outside in, one is inside out, and then is mark and meet, where you put a mark in the center and you come from both the side and meet in the center. So you see this. You have to, very important, focus in the infranasal quadrant because that is where your collectors channel are in highest quantity there. So you, and mind you that, you know, whatever the fear was there, it is hardly anything. There is a very little learning curve in this. You just do 1 or 2 cases and then you are good to go in this. And the surgical time is very, very less. In fact, if the last 2 days back only I did a standalone MIGS surgery, and The surgical time was less than 2 minutes. So this is very important. How do you, you have to place Helon on the cornea, or you can put on the lens also, goniotomy lens. You put Helon on the cornea, and you don't have to use any other viscoelastic. You have to inflate the AC with Helon only. And this is, you have to rest your hand on the forehead so that there is no movement of this thing. Do not use lens for directing the eye, because that is not correct. You will not get a good view of the angle. And then once you are there in around the angle, then zoom in. This is on the left side, this is the starting position of the microscope, which is normally what you use for cataract surgery or any other surgery. You have to move the microscope 30 to 40 degrees away from vertical, and then lift the eyepiece, because then it becomes otherwise not possible to operate. You have to lift the eyepiece. The newer, there is a microscope, C Luma, which is being branded by Bausch & Lomb. They say this tilting of headpiece is not required. They are going to launch it next year. So you have to ensure 3 perpendicular planes, that is your microscope, iris, and goniotomy device should be perpendicular. How optimal gonioscopic view should look like this. Like any other cataracts, one very important tip is that you have to go clear corneal in this. You cannot go around the limbus, because if you have little bleeding, then it's going to obscure your vision. You have to, like any other this thing, you have to tilt the tip and enter inside. Then once you release the trabecular meshwork, level is off. That means you become horizontal, and you have to put the heel first, make it flat, heel first, dip it perpendicular. The tip has to go perpendicular into the trabecular meshwork, and then make it flat. Then it goes horizontally in a smooth single. You cannot have a jerky movements. It's a smooth single motion, and it goes smoothly. You can do any of the technique, and then it has to go in one smooth motion. As I told you, the foot plate has to be seated well, and this is how you have to do it. As I told you earlier, reflex of blood is very important. You have to see that, and that is a good sign. And at the end of the surgery, you have to have a little higher pressure. That means you have to inflate the AC, and you have to maintain a pressure of around 25 to 30 millimeters of mercury, and you have to put air bubble in this so that you prevent further leakage of blood vessels. These are the things what if you have bubble, you again put extra OVD. If you are having corneal, you will have, initially you tend to put more pressure. You will have corneal stars, so apply less pressure, inflate the AC again, relax your instruments, and if you are not able to see this thing, you can stay in the trabecular meshwork also. And post-operative is very, very important. Apart from normal routine cataract, you have to put these patients on pilocarpine, 1 drop at night for a month. Very, very important. And as far as IOP, I stop all IOP lowering drugs on day 1 itself, and then titrate my patient as the patient goes on. And this is my experience that I've done around 62 MIGS surgeries. After 4 months of follow-up, those patients who were on 4 and 5 drugs before the surgery were shifted to 2 drugs only in 26 cases, and in 1 or 2 drugs. In fact, few patients have gone off their drugs in almost 36 patients. Thank you. And this is what is the final this thing.